everybody to. No.
Yeah, they are good.
Very good. And maybe I'll just ask everybody to mute. So we're welcome everybody to the Leong Center rounds this morning. I'm really delighted to introduce Professor Ruth Gilbert. Professor Gilbert is a pediatrician and one of the world's leading experts in child health policy, and in particular the use of large administrative data sets for research. She's a co-director of the NIHR Children and Family Policy Research Unit and a professor of clinical epidemiology at University College London, and senior scientist at the Great Ormond Street Institute of Child Health. Really delighted. She's also a member of the Leong Center International Scientific Advisory Committee, and on a personal note, a very important mentor to me. So delighted that Professor Gilbert is here and that her slides are loaded. And then we'll have questions at the end. Maybe put them in the chat. If we have time, I'm happy to call on people so that they can actually speak to them. But if we're a little pressed for time, I might just try to read some of them out. All right, Ruth, welcome, and on to you.
Thanks so much, Astrid. Can you hear me okay? Yeah, great. So
yeah,
thanks so much for that introduction, Astrid. It's been really interesting to attend this seminar series, and I feel really honoured to speak about children's pathways through healthcare, education and social care services. So I'm going to talk about the ECHILD database today, and this is a newly developed administrative data resource which includes linked de-identified hospital education and social care records for all children in England. So I'm going to briefly discuss why we created ECHILD, what it contains, and outline how we're addressing governance challenges and endeavouring to maintain public trust. Lastly, I'm going to demonstrate or illustrate the value of ECHILD with some brief examples of research. So why create the ECHILD database? So we know that children's health and education strongly influence their lifelong health, education, employment, earnings, and quality of life through adulthood. So ECHILD's valuable because it measures children's health, education, and social welfare characteristics to some extent right across childhood. So we can use this information to understand how these characteristics interrelate across the life course and how they vary by indicators of inequalities such as deprivation level, ethnic background, community, or geography. Secondly, these administrative data also measure provision of services. So as the report by Sir Michael Marmot, Fair Society, Healthy Lives, which was published in 2010, highlighted, reducing the steep gradient in health inequalities across the whole population requires universal services that benefit all, but deliver the most intensive support to those who need it most. So ECHILD could be used to assess whether interventions are being delivered by these three universal services in an equitable way. Is healthcare, education and social care providing services to all, but most intensively to those who need them most? So ECHILD was created through a government researcher partnership with support from the Administrative Data Research UK. The aim is to make the database widely available for research, including government researchers and academic researchers. So government and the government departments and the wider academic research community certainly have common interests, but historically they've had different approaches. So for example, in England, government analysts often focus on using the data in cross-sectional form, which limits the scope for inference across the life course. So this is one area where a partnership approach in which data are generated for both government and academic researchers can really add value. So in a nutshell, ECHILD brings together data from 2 government departments. Data are already collected from schools and social care by the Department for Education, and that database is called the National Pupil Database. Similarly, data are already collected from hospitals by NHS Digital, and that's called Hospital Episode Statistics. These data resources have been widely used for research for decades, but they have not been linked together before in England. They have been linked together before in Wales and Scotland, who are often in advance of England in data matters. So to create ECHILD, we linked information from MPD and CHES for all children in England who were born from September 1995. And we linked nearly 15 million children currently, and that increases each year. The data are de-identified and they're held securely in the Office for National Statistics Secure Research Service. So what type of information does ECHILD contain? Hospital episode statistics comprise individual records for all NHS patient contacts with hospitals in England. It includes all admissions, and that contains patient demographics and standardized codes for diagnoses and procedures. CHES also has data on NHS emergency department visits and on outpatient appointments and attendances and all death records. So these data can be used to assess patterns of unplanned care and planned care, and we use it to develop phenotypes, meaning classifying groups of children with codes that indicate certain conditions, so certain chronic conditions or, for example, mental health related presentations. The National Pupil Database contains a full chronology of pupils' school careers within the state school system. So 96% of all children in England attend state school at some point, though only around 93% in any one year. So key measures in the National Pupil Database are pupil demographics, school absence, special educational needs, exclusions, temporary and permanent, and pupil attainment scores. Social care data includes referrals, whether a child is deemed to be in need of support, and start and end dates of periods of care, mostly out-of-home care. The demographics from these data resources are really important for studying inequalities. For example, both MPD and CHES include ethnic group and area level deprivation measures, but MPD also includes first language spoken at home and receipt of free school meals, which is a measure of household receipt of welfare benefits, and that affects about 17% pupils at the moment. And we also know quite a lot about the characteristics of each school. Lastly, and most importantly, is the pseudonymized linkage spine, which contains anonymized linkage keys for MPD and CHES for each child, so that the researchers using these attribute data can link the data. As many of you might have experienced in Canada, as is often the case, then data collection varies over time and different modules start up at different times. So one needs to take this into account when designing studies. So for instance, CHES admissions start from 1997, but the main pupil census doesn't start until 2001-2. But although there are some test results and social care results before then. So these data provide rich longitudinal information, particularly through repeated pupil test scores. So in England, national testing of children in state school is a key tool for holding schools to account. National pupil test scores are used to assess the added value of schools, and they're published in league tables to promote choice and a market in education. So currently there are 5 national tests. The 6th was withdrawn in 2013. So against this background, we can follow children through hospital data for over 20 years from, as in this exemplar trajectory, from a birth record of a girl, where we can follow her through from her own birth to a record of her pregnancy and her delivery in her early 20s. In this exemplar trajectory, we can see that she's had prior admissions for injury and self-harm. But when we add in school records, we see that she also received some special educational needs support in primary school, which was discontinued. And then she had frequent absences and scored lower than expected in her GCSE exams. That's the public examination, a high stakes examination at age 16, which really determines important determinant of employment and higher education. If we add in social care to this, we can see a referral to social care services in primary school and entry to looked after care a few years later, with a move to independent living at age 16. So this trajectory raises questions that could be addressed on a population basis by using ECHILD data. So for example, one question is whether more sustained support or earlier support for children like this, in terms of special educational needs support or social care support, might have led to different outcomes. So governance has been challenging. You can see from this timeline at the bottom that we started working on data applications to NHS Digital and the Department for Education in 2014. And we didn't access the full ECHILD database until 2021. For the first part, we addressed challenges by working in feasible steps, as ECHILD is the first linkage of person-level data between health and another government department. So it was bound to receive a lot of scrutiny. So we followed Department for Education advice from the start off, and we asked for minimally sensitive data and minimal amounts of data, just 4 one-year cohorts, so that we could set a precedent and test the technical feasibility and accuracy of linkage. Getting these 4 one-year cohorts took 6 years from our first conversations, and it went through different teams of lawyers at NHS Digital and Department for Education multiple times. Eventually, we were able to access the linked data in spring 2020, but by then we had further funding, and we also had strong support from the Department for Education and the Department of Health to make this work. COVID then arrived and caused delays, but it also brought a climate of increased linkage and use of administrative data, and we eventually accessed the full ECHILD data in June 2021. So we face ongoing challenges. Scaling up wider use of ECHILD by government and other UK researchers is proving challenging, and we're having to pursue several options on this. Also challenging is refreshing the data each year and getting permissions to extend the data sets included. I think the core problems here are firstly the limited capacity of these government data providers. A second problem is extreme caution, particularly around health data, and that's often triggered by media coverage of opposition to sharing of health data. This last issue highlights the importance of involving the public and demonstrating their support. And that was really important right from the start. So this red arrow shows that back in 2014, even before we submitted data applications, we consulted 3 national children's charities to hear their views about ECHILD, how it could make a difference, and whether they had any concerns about linking health and education data for research. They were very supportive, and their letters of support were really important to get us through ethics approval and important for our data applications to the data custodians. So public engagement has been ongoing, and particularly over the last couple of years has involved facilitated groups of young people, children and parents. So, for example, we've worked with 12 groups in the last 18 months, involving about 180 participants. We also have parents on our ECHILD advisory group and several more involved in specific studies. We also hold formal and informal meetings with stakeholders from charities, government services, and practitioners. And we do this through things like meetings like question and answer sessions, which this report is a publication from, seminars and user group meetings. We see transparency is really important. So we publish website summaries of what young people and parent groups tell us and lay summaries of our research for them. So moving on to examples of research. So firstly, I want to show the evaluation of our linkage accuracy, and this was work done by Katie Harron and Nicholas Lebuy. As there's no shared unique identifier, linkage between National Pupil Database and hospital data firstly involves linking full names, postcodes, date of birth, and sex across the whole chronology of available education years to the NHS spine. So that's stage one, and the NHS spine is called the Personal Demographic Service. We then had a second step involving linking from the spine to HES data, hospital episode statistics, using NHS number, which is mostly available, but less so in earlier years, plus date of birth and postcode. And thirdly, there was the step of linking attribute data using the pseudonymized linkage keys. So missed links occurred at each of these steps. But the proportion of children in the National Pupil Database who linked to a hospital record was surprisingly high. So 92% of those with records in the National Pupil Database born in 1990-91 linked to a HES record, and 99% of those born in 2004-05. But children who linked at a later step in the algorithm, or who didn't link at all, were disproportionately non-white or poorer, suggesting that data quality is a problem for these more disadvantaged groups. So this minor loss of accuracy will marginally underestimate healthcare needs for these pupils, particularly in the earlier years, and it's much better later on. So moving on to another study of inequalities in outcome, when we finally accessed the full ECHILD database in June 2021, our initial priority was to understand the impact of the COVID pandemic on access to hospital care for vulnerable children. So in this study, led by Louise McGrath-Lone and Ruth Blackburn, we classified vulnerable adolescents based on those who received statutory support, either from schools for special educational needs or from children's social care. And this support was received in a one-year period before the COVID pandemic. So you can see here 21% of adolescents aged 11 to 17 received statutory support. And here you can see them grouped as SEN only, 14%, both SEN and social care, 3.5%, and social care only. We found that deficits in hospital contacts during the pandemic were greatest for adolescents who received statutory support, much greater than for their peers. The deficit was calculated as the difference between predicted versus observed rates of hospital contact in 2020, assuming that previous time trends would have continued had the pandemic not happened. So the bars on the left show the biggest deficit was for outpatient appointments. Adolescents with any statutory support, shown in blue here, had a bigger deficit than their peers in grey. But those receiving both special education needs support and social care support had the largest deficit. And these patterns were similar for planned admissions and unplanned admissions, though with lower rates. Deficits in planned care likely represent treatment, diagnoses, or procedures forgone or delayed and may have health consequences. and they could be long-term. So although 21% of adolescents received statutory services, they accounted for 37% of the deficit in planned admissions for all children. And it's this group that particularly needs targeting for catch-up strategies of planned care post the pandemic. On the other hand, the deficit in unplanned admissions is a more mixed picture. It may represent a benefit of lockdown, which reduced admissions due to infection, injuries, and risky behaviour, but might also represent failure to meet needs for some acute conditions, including mental health disorders. So if we look across the whole of childhood, or the whole of the school period, we see that many more children receive these statutory services, and these two types of support are highly interlinked. So in this study done by Matt J, he followed children from school year 1, age 5 to age 16 to calculate the cumulative incidence of special educational needs support. He showed that overall, 41% of all children ever received special needs support. But by age 16, 83% of those who had ever been placed in care, in out-of-home care mostly, received SEND support, and 65% of those who ever received a social care intervention but were not placed in care in the school years. The white line shows that for those who did not receive any intervention from children's social care, still 34% of them received special educational needs support at some point. So we have much more work to do to understand the health characteristics and health needs and outcomes for these groups. But we know that their education outcomes are poor. This graph shows further work from Matt J, where he estimated the probability of non-enrollment in school at the ages between ages 14 and 16, based on a regression model where the exposure was levels of social care, and this was moderated by whether the child received SEND support or not. This model was adjusted for ethnicity and deprivation and accounted for variation by region. So the main message in this graph is that adolescents who received special educational needs or social care had higher rates of non-enrollment in school aged 14 to 16. Now all children have to are mandated to be in school up until 16. Those receiving both types of support, the red line and the right-hand 3 dots, had the highest rates of non-enrollment. So what does non-enrollment mean? It could indicate pushing out. I understand that's a North American phrase. In England, we'd say off-rolling by the school. This is an illegal procedure. It could mean the child absconding, but that would have to be for a whole year. It could indicate home or private schooling, but that's very unlikely in these analyses, as we excluded anyone who sat 5 or more of the public GCSE exams at age 16. So it seems counterintuitive that around 10% of adolescents with very high needs are not enrolled in school, 4 times the rate of their peers. So these findings certainly reflect inequitable provision, and they may reflect a lack of resources or capacity within schools to deal with these children with very high levels of needs. High rates, increased rates of non-enrollment may also reflect market incentives to deselect disruptive pupils before exams that contribute to league tables. In the last 2 examples, this one and the one about vulnerable children in the COVID pandemic, we defined our cohort based on children in schools data, and then we followed up their health or education outcomes. The next example, again by Katie Harron and Nicholas Labui, they started off by defining children in the health data, defining them in HES by creating a national birth cohort from birth episodes. And this captures, HES captures 97% of all births in England. And they followed those children forward into their education records up to the age of 11 to measure their prognosis for educational attainment or for special educational needs up to 11 years old. Now, I know many other jurisdictions with this type of linked data have similarly assessed education outcomes according to gestational age at birth. So this gradient will be really familiar. In addition, this study stratifies results according to the presence of chronic conditions recorded in hospital records before the age of 2 years. So the outcomes shown by the bars are the proportions of children not achieving expected levels of attainment at their Key Stage 2 tests at age 11 or Key Stage 1 at age 7. So the graph on the left shows the gradient for those with no chronic conditions. And what you can see is that 33% of those born before 32 weeks of gestation did not attain expected levels at age 11, compared with 20% of those born at 40 weeks. But these proportions are much higher for children with any chronic condition and high for cardiovascular and they're highest for those with cardiovascular conditions or neurodevelopmental conditions. Now, I don't know if there's anyone from Manitoba here, but I should say at this point that although gestational age at birth and chronic conditions are important prognostic factors at individual level, at a population level, these characteristics account for only a small proportion of lower than expected attainment or SEN provision at age 11. Other factors, such as social factors, are really important, and this is consistent with evidence from Manitoba that we all learned about around a decade ago. So lastly, I want to briefly outline a new study at UCL which aims to assess the effects of special educational needs support in schools on health outcomes. It's called the HOPE study, Health Outcomes of Young People in Education. As in the previous study by Aaron and Liburi, we're using healthcare histories from birth onwards to define phenotypes or groups of children likely to need special educational support. And we're doing that regardless of whether they actually receive SEN provision or not. Secondly, we assess variation in SEN provision across schools and local authorities and over time, so that we can then compare children with similar health needs, similar health phenotypes, who by virtue of their school or the area that they lived in received special needs or not. SEN provision is well known to be a postcode lottery, and provision has declined over time. So we'll exploit this type of externally determined treatment variation, getting SEN provision or not, using different causal measures to assess different causal methods to assess the impact of timing and duration of SEN provision on health outcomes overall, and to assess which groups, which phenotypes benefit most and at what point in the school histories. So in summary, ECHILD can be used to generate evidence on health, education and social welfare characteristics across the whole of childhood, and it can be used to look at equitable provision of services. It contains longitudinal administrative data of service contacts from birth to adulthood, but it doesn't contain everything. It misses primary care, it misses drug treatments, it misses biological or diagnostic test data, and there's no patient or pupil reported information. Governance and public trust is continually challenging and requires ongoing public support and stakeholder involvement. And lastly, I think the research potential is huge, but it's limited by obstacles of accessing the data and analytic capacity, which we need to really build. So finishing up, I just want to thank our government partners in ECHILD from NHS Digital, Department for Education and the Office for National Statistics, my academic colleagues who are working on ECHILD and our funders, particularly the Administrative Data Research UK. Thank you very much. So now I'll try and unshare.
Thank you very, very much, Ruth, for a really interesting presentation. As you probably know, some provinces and, the work of Manitoba obviously really well have managed to achieve sort of similar linkages, and we've been at it in Ontario for, I'm going to say 15 years, but making some progress. I'm going to open up to questions. I have a question just to start, which is, something that we talk about a lot, which is just this whole notion of joined up government and ways in which different, ministries sort of work together on problems that obviously are important across sectors. And I'm just curious, whether there's, with these sort of data linkages, has there been any parallel in the way in which policymakers are thinking about policy that sort of crosses some of the sectors, and whether any of the sort of this activity with data and conversations about what to do with it have sort of spurred any of that on?
I think it's early days. I mean, it's certainly, we're starting to see Department for Education coming into seminars with Department of Health and vice versa. And we're seeing sort of different questions being asked. So for instance, one of the big surprises, I think, for Department for Education is just how huge that proportion is of children cumulatively who have received social care or cumulatively receive special educational needs. And of course, they're a very expensive group also for health, children with complex needs. But I'm not seeing formal join up yet. I mean, of course, these government departments have their, long-standing links, but the crosstalk I'm seeing is through the research rather than being organised outside as yet.
Yeah, it's interesting.
Yeah.
Claire, do you want to ask your question?
Yes, definitely. Sorry, I have a bit of a cold, so I apologize. I'm just wondering, Ruth, can the ECHILD database be linked to the CPRD and or the MHSDS? You mentioned you didn't have those records.
So I think the biggest gap is that we don't have it linked to primary care data, which is, for other people, is what you mean by CPRD. So I think that would be the biggest priority in health data that we would want to link to. And in fact, the MHDS, I think you're meaning mental health data, it would also be important, but a lot of mental health care, even for children, takes place in general practice. So it's that community prescribing data that we'd see in primary care data and diagnoses that would be really, really important. That's where the biggest sensitivities lie at the moment, is with sharing primary care data. So I think we're some way from that, but I think we need to keep pushing. I think it's very important.
Thank you.
So it can be, but it hasn't been yet.
Catherine, I see your comment. Do you want to ask a question about it, or?
So is this about the air pollution, or it's?
No, it's the one above that.
A bit of a rant. Thanks so much for the talk. I guess I was reflecting on the achievements you've made in terms of data access and linking existing data. I think we have some further difficulties here in Ontario and Canada because the data isn't actually collected consistently. For example, in the last few years, we have not had our several of our standardized measures in schools collected in children. So I wonder if you have comments about that.
Yeah, well, I mean, you can see maybe I sort of suggested it in my body language that, that's a double-edged sword. The fact that we have so many tests in England, it's perhaps not great for education because people are teaching to the test all the time. But it gives us lots of data from the age of 5 onwards. And those are national tests. So it's really useful that we have this. What we don't have, which I think you have in Canada, is you have our 5-year test, I think is not quite the same as your school readiness test. We have a 2.5-year test that's administered by health visitors, and that's really poorly collated at the moment. And so we'd really like to, see we're in the same problem as you are with that 2.5-year test, in that can't be then compared with subsequent test results. We're far away from that. So yeah, we've got lots once they get into school, and it's very useful.
Yeah, we actually have Magdalena's on the line as well, and who's obviously been developed the EDI and has been instrumental in its rollout in Canada. I'd say it's there's also big interprovincial differences. So there are interprovincial differences in Canada around which provinces have had the legislative authorities to link these data. But the other is also some of the other data besides, like the testing data. So you talk about the absentee data, and we had lots of discussions with government in Ontario a few years back around an evaluation of the mental health strategy. And in high schools, they do not have electronic absentee data. That may be changing. So electronic for elementary school, but in high school, they had no database, even for their own purposes, forgot about linking around school absenteeism, which is like such an important, construct, so important around mental health and all of that. So yeah, I think, all important. Teresa, do you want to ask your question?
Yes, thank you, Ruth. I really enjoy your presentation. That's great. I have 2 questions. Maybe I'll ask the easier one first. A lot of people are interested in lifestyle risk factors, like smoking, drinking, vaping, that is now becoming an epidemic among young people at the age of youth and teenage. So do you have that kind of individual level data that you could link to these databases to assess the impact of these lifestyle risks?
Yeah, so Teresa, it's a really good question. And there's very many surveys and self-report surveys, patient-reported surveys that I think it would be really helpful to link in. So for instance, we've got a really large survey that was started in 2017 and then repeated, I think it was on the third wave at the moment, called Mental Health CYP. That's about 10,000 participants across England. I would love to see that linked in to this data. So it's got very well standardized data on self-reported mental health and risk behaviors like you're mentioning. We're not there yet with the governance, but I think this is a platform that would be brilliant for bringing in other surveys and of course trials and nesting, large cohorts, birth cohorts and other cohorts within this. So no, we don't have that. I see your other question is about air pollution.
Right.
We're certainly looking at this and trying to get funding to do this. What we're particularly interested in doing is, at the moment, we can't. Of course, it's de-identified data, so you don't have any resolution of where these people are. But what we want to create is a de-identified household ID, so to which other environmental characteristics can be linked, and in fact, other household characteristics such as household income is, I think, what we really need. We only have area-based measures at the moment. So we're looking at doing that, and we're at a time where this unique property reference number, this household ID, is being used more widely in practice. So it's something we really want to test out in ECHILD, but we're not there yet. And what we will be able to do then is to look at the child pollution levels at child's residence as well as schools. So, people are already looking at pollution levels in schools. That's linkable because you know where the schools are, but the residence for individual pupils is de-identified.
That's wonderful. I think even at the school level, it would be helpful because especially for the younger students, because during the breaks, they actually would go outside and play. And if their school is in a polluted area, they would have, much more opportunity to breathe in these dirty air that may affect.
Yeah, that's already possible. Yeah,
that's great. And the other comment is, the lifestyle risk factor. I wonder how much it may explain your low level of enrollment at age 14 and 16, because one of your slides showed that, the percentage of enrollment was low. I wonder, whether that has anything to do with those risky lifestyles at that age. So it would be something good to look into.
So this is enrollment in they're not enrolled in school.
Yeah,
they should be enrolled in school and they're somewhere else. And probably, they're somewhere else out on the streets and there's lots of high risk behaviours going on, but they might not respond to be the sorts of kids that would respond to self-report surveys to get that information. But we will be able to see those children coming into NHS services, so we will see them coming in with injuries, mental health problems and so on.
Wonderful. Thank you so much.
Thank you.
Magdalena?
Thanks very much. I really enjoyed your presentation. I think one thing that before I get to my question, I think one thing that really strikes me is there are no perfect databases. There are certain things that people have in some countries and some things people have in other countries. It would be, really nice in the future to be able to kind of harmonize, not just within a country, which is a big issue for us here with the provinces, but even, more so internationally. And, in terms of the early kind of 5-year assessment, it's really, there is no real truth. Like some assessments, some things are best assessed directly, and some are really great when teachers provide their reports. But my question is very specific. It's a common problem that we, especially when we study children and youth, we have no information in databases on children's gender. And I was just wondering whether you have a way to address that.
Yeah, so we just have what's recorded as sex in both databases, and we will see that repeatedly over time. Yeah, that's all we have. I mean, I think this is an area again, as I said to, I think it's Teresa, where self-report surveys linking in factors related to identity could be really helpful.
If I just can make one comment, in Ontario, for example, the problem then is missing data, because in Ontario, in data that are not yet linked through ICS, but we're working on linking EDI to educational data in other channels, there is a self-report about self-concept, but there is a lot of missing data. When students after the test are supposed to complete it, it doesn't always happen, right? Yeah. So that's another. Okay, thanks very much.
Thank you. Thanks.
Thanks, Magdalena. Dennis?
Just have to unmute. I think your databases are absolutely incredible, and I think you partly answered my two questions. The one is whether you can get regional informational, and the other is how much of the social determinants of health are in your databases. I think you've answered that, but you may want to comment some more about those two things.
Yeah, thank you. Great question. So yes, we can look at, we can say quite a lot about region and local authority. We can say quite a lot about the schools. If you know anything about England, you'll know that there's very different types of schools now. There's academy chains and so on. So we can look at those variation in those sorts of units, and yeah, we see north, south, east, west divide as you'd expect. And we have power in the numbers to look at quite sort of detailed breakdowns. You were also asking about things like household income and so on. Is that?
Yes.
I mean, that's all we have is the free school meal status, which is basically whether they're eligible and they've claimed for free school meals. And that's based on welfare benefits. So that's around 17% of pupils. So it's no more granular than that, but at least that's a pupil level factor. The rest of the time we're dealing with index of multiple deprivation, or the income deprivation measure, which is based on a lower super output area, which is on average around 1,500 individuals. Or around 650 households. So it dilutes we expect to see really big gradients by income deprivation, by poverty in health and education outcomes. But these are really blunted because we have these area measures rather than individual household measures. So I think it's a priority to get household level income, and I think it's feasible, but we're talking about data that is delivered by the Department for Work and Pensions, and yeah, they haven't made that available yet.
Highly protected.
Thank you.
Yeah. Well, it doesn't need to be protected because it's not disclosive. All we'd be asking for is sort of strata by household level. And it's so much more revealing about these sort of gradients of inequalities by income, and very important for policies on welfare benefits and so on.
Yeah. But it's interesting. And I know you were at the Statistics Canada presentation, and at the Canadian level, there's sort of willingness, there's linkage of those individual types of data, but at the provincial level, with ministries of finance, it's been really hard, even in provinces where many other child welfare, all sorts of linkages have been made. There's real resistance to sharing tax file data, so it's interesting.
Yeah.
I wonder if maybe I'll just end with a question and a little preamble, which is that, we at the Leong Center have some funding to start a program of student exchanges, and, very interested in working with different partners on that, including, UCL and your group. Do you think that it's feasible? And what would timelines be if a graduate student, and let's say, PhD student or even a postdoc, wanted to come over and do a project with you using some of these data, given sort of the difficulties in data access? Like, what kind of a timeline do you think you would need to facilitate something like that? I'm just curious as we start to think about this.
Yeah, I mean, I think these are quite complicated data, so I think it's the person needs to be spending time here. It's not a 3-month project that we've been talking about. I think you need longer than that, with all the access and training and so on, approvals that are needed. So much better to have a year than a shorter time. In terms of getting access, I just have to say we don't know yet. We're working on at least 3 strategies for widening access for other projects and for external researchers. I mean, hopefully all 3 will work out. And it may be that could be, optimistically, moderately quick, so months rather than years. once those governance processes are in place. But we're not there yet. And sorry, I'm fed up with being at talks where I have to say that we're not there yet, because I think it is so important. There's so much that can be done with this data. But just in terms of, I think it was Magdalene who suggested international comparisons. I mean, they're always difficult, and Astrid, we've done lots of them, and we have to be, cautiously interpreted. But I think it is really an interesting question that, particularly for children with chronic conditions or children that are born, extremely preterm and so on, how much do they differ from their in-country peers as they go through childhood? And for instance, do countries with good support for additional needs, special educational needs, and for behaviour problems and so on, learning impairment, do we see narrowing of some of these health and educational outcomes compared with countries that don't have such, or haven't invested so much in support for children with complex needs during school? I think there's definitely something to be done in that sort of area.
Yeah, agree. Any last questions before we thank Ruth very much? No. Well, with that, thank you very, very much, Ruth. It's really, really interesting, and we definitely hope that we'll be able to collaborate more. We hope we'll be able to get to a point where we also have some of these data linked in Ontario, and so that we can start to contemplate some of those kinds of cross-jurisdictional studies, and that we might be able to offer some of our students the opportunity to work with your amazing group as well.
Yeah, well, and likewise. So yeah, good luck with it. Thank you. Bye.